Hi, my name is Ho-Chan Gillis. I'm a nurse practitioner in Richmond, Virginia. I've been working in hepatology for the past 25 years. So I would like to discuss, why it's important to distinguish between the advanced fibrosis stage 3, I'm going to call it F3, and cirrhosis F4, and why it's critically important for patient management, prognosis, and surveillance strategies in MASH. Well, as you know, both F3 and F4 fibrosis stages are associated with increased mortality risk, both liver-specific and overall mortality. The fibrosis stage 3 or F3 carries an increased risk of progression, but potentially it's reversible, especially with interventions like lifestyle modification, specifically weight loss, or pharmacotherapy. F4 fibrosis or cirrhosis, often represents an irreversible architectural change or distortion in the liver and is associated with a significantly higher risk of liver-related complications such as portal hypertension, variceal bleeding, hepatic encephalopathy, all things that are associated with portal hypertension, but also an increased risk of hepatocellular carcinoma. And for those that have diagnosis of cirrhosis, you want to do preventative strategies like getting an ultrasound with an AFP every 6 months to screen them for liver cancer. When irrelevant, if their FibroScan or according to the Bovino criteria, if their FibroScan is greater than 20 kilopascals and their platelet count is under 150,000, you want to screen for clinically significant portal hypertension, including upper endoscopy for variceal screening. And also you want to monitor these patients for decompensation. There is very limited data on F3 disease for, HCC screening unless they are high risk. And also if they have other risk factors. But again, F4, even though if you feel like you're splitting hairs, F3 and F4, there are different clinical entities. Also, many clinical trials and current FDA therapies, the only one, which is Rezdiffra, is indicated in those with advanced fibrosis. So you're looking at stage 5, F2 and F3. There is not enough data to use in cirrhosis, even in the compensated population. So it's important to accurately distinguish between F3 and F4 fibrosis and MASH. And although it may be challenging, but the distinction between is the cornerstone of, I think, personalized care and risk stratification that guides surveillance, treatment, and also preventive strategies to reduce overall risk of mortality, specifically liver-specific mortality. So the other discussion point I wanted to review is discussing the accuracy and limitations of the various non-invasive tests that are available, including serum markers, FibroScan, also VCTE, which is vibration-controlled transient elastography, and MR elastography, and differentiating between F3 and F4 fibrosis, where they perform well, where there's overlap. So although we have serum biomarker panels such as the FIB4, the MASLD fibrosis score, NFS, APRI, or the enhanced liver fibrosis test, although they are widely available and relatively inexpensive, the ELF test can be expensive, but but other biomarkers like the FIB4 and the NFS and APRI, if you have, common lab tests, you can easily calculate them. They're good at ruling out significant fibrosis, like the low risk, and identifying the high risk, those with a greater than F3. But because there is a lack of granularity distinguishing between the F3 and F4, and also some of these biomarkers based on the parameters, it could be influenced by age, transaminase levels, especially if they have very high ALT, ASTs, inflammation, and other comorbidities. You often see an overlap in the values because, even if they have F3, F4, you're still using parameters like lab tests like ALT, AST, platelet count, age, which is cross in between, it's captured in both patient populations if they're F3 or F4. And you can often see overlap, and also especially those with obesity or their significant multiple metabolic comorbidities. The vibration controlled elastography, also known as FibroScan, is a measure for or a surrogate for liver stiffness. It's better probably in discriminating between fibrosis stages than serum blood tests. You have established cutoffs for low risk, which is under 8 kilopascals. But for like the F3 versus and distinguish between F4, you can use different cutoffs, and there are various cutoffs in the literature. But I always talk about the sweet spot, as far as trying to identify those with advanced fibrosis, which is F2, F3, with a FibroScan kilopascals between like 10 to 15. And often you can see, patients with F3 for a little higher than 15. But those with a cutoff of greater than 20, you want to worry that they may have clinically significant cirrhosis or portal hypertension. So again, there is some overlap, between F3 and F4. It can be difficult, to sometimes distinguish between those in clinical settings, and you may need, additional like physical exam or other type of parameters, imaging to help you determine, or distinguish between, differentiate between F3 and F4 disease. We have imaging like MRE, which I think is a great tool. But the problem is that it's pretty costly, and there's limited access. It's often confined to, academic centers, and it's not readily available. But I always also think about, standardization, because I can get, depending on the source of the MRE, I've seen reports, and it would be helpful if we can get some standardization in radiology when they report those. But again, there is some overlap, but there are some established cutoffs between F3. You worry about the cutoffs are like low risk is less than 3.3, but for F3 it could be somewhere around 3.7 to the 4.5 kilopascal range. And then some areas, when you're concerned about F4, you often see the kilopascals on MRAs greater than 4.5, 4.7. So again, it's not always, feasible for routine monitoring at all, in all settings. Again, very difficult when there's differentiating due to overlapping, scores and ranges. So, also, what do you do when they're indeterminate or borderline between F3 and F4? I think when should you pursue a liver biopsy? Liver biopsy to use for definitive staging is coming out of favor, especially with the battery. And so non-invasive tests, because no one really wants a needle in their liver because it's invasive, it's painful, and, often confined to clinical trials. However, I think that there may be a role for liver biopsy, and especially if it can impact the, management decisions, and would distinguishing between F3 and F4 change a care plan? And absolutely it would, because, when you have cirrhosis versus F3, there are totally two different, even along the spectrum of chronic liver disease, the treatment goals differ in those settings between F3 and F4. If F3, they may be eligible for pharmacotherapy or clinical trials. And if they're F4, you want to monitor them for disease progression, but also liver decompensation. And if they're have significant portal hypertension, then you want to consider transplant referral if decompensated. So oftentimes I, will use the biopsy if it's going to change. But if I do, and I really want to prove that they have cirrhosis, oftentimes, if I'm going to do a biopsy, I'm going to order a transjugular liver biopsy, because you can have the interventional radiologist not only get a biopsy core sample, but also they could do direct, portal pressure gradients to help you determine if they have clinically significant portal hypertension. Oftentimes, even though we have access to a lot of non-invasive testings, we see a lot of discordance between, the FibroScan or an MRE, or we see discordance between serum markers and imaging. So sometimes, that would help us distinguish or verify the stage of disease. And most often why I would biopsy someone is if they have an atypical appearance or they have some, other suspected coexisting diagnosis. If it just doesn't really make sense, it's not clearly MASLD, even though I've ruled out extensive alcohol, I've done a PET test, but, if they're not really fitting in that bucket or there's, other suspicion like, iron overload or granulomas or autoimmune disease or drug-induced liver injury with overlap, that would be a good indication where, you would pursue a liver biopsy. There are certain situations where I would not do a liver biopsy, but also if I have someone that is young and where staging matters for long-term, planning, I think that would be another situation where I would do a biopsy, especially in the realm of discordant and non-invasive tests. I think that, liver biopsy remains the gold standard when precision is really critical. But I think in today's world, we need to maximize non-invasive testing and reserve, biopsy for those rare decision situations where there's uncertainty remains despite having a good non-invasive test. So that would be my approach, to distinguishing, between F3 and F4. I think a lot of the goals and lifestyle management and reducing cardiometabolic risk management is equivalent in F3 and F4 disease, but I would tend to be more aggressive, especially since, patients that have cirrhosis not only have a higher risk of mortality, of liver-specific mortality, but they're still, the number one cause of death in these patients is cardiovascular disease. So, and also the treatment or preventative strategies are very different. In those with fibrosis, you want to make sure that, you're screening for hepatocellular carcinoma. It is scary, though, that we are seeing increased incidence of hepatocellular carcinoma in those with, without overt cirrhosis. And I think that, in some cases for F3, it's a good justification to do ultrasound surveillance, especially if those, want to make an individualized decision. If they're older, if they have multiple metabolic risk factors, or they have a family history. So, those things should be considered, but, there is, I think the goals of treatment and management is very different. F3, you're trying to prevent progression to F4. And again, emphasizing the cornerstone of foundational therapy, which is, lifestyle modification, weight loss, and also appropriately identifying those patients for pharmacotherapeutic medications that could reduce their risk of, liver-specific mortality. So I think that in MASH, confirming, F3 and F4, you're in the fork in the road, but the transition from fibrosis to cirrhosis really requires a comprehensive shift from disease-modifying strategies to surveillance, complication prevention, and really prognosticating their mortality. And I think misclassifying cirrhosis as F3 can also be harmful and can lead to missed surveillance opportunities or worse outcomes, undercovering the importance of really accurate staging. So you don't want to miss patients with F3. You don't want to misclassify patients with, with cirrhosis. But I think it is sometimes difficult and challenging in clinical practice, but, the treatment strategy is very differently from those populations. So I really appreciate you tuning in. Thanks.